Okay, so Twiggy and
Cubby.
and we've made our way to the kitchen, and I'm just going to sit down with Marty Hatlie. Marty, I lovingly call him, and I don't know if you like this title or not, but I lovingly call him the grandfather of person and family engagement. Is that fair?
Of one branch.
Of one branch of person and family engagement.
The branch that focuses on safety and quality.
Okay,
Yes.
the branch that focuses on safety and quality. Fair enough. I have been working with Marty for, gosh, it's been close to 3 years now, I think.
Wow.
It's been a while, and we've done quite a lot of work together in the field of patient and family engagement within the context of medical safety. But today I really want to hear from you about what you're prioritizing right now, especially with regard to this moment of the second annual World Patient Safety Day, September 17th, and the Unite for Safe Care, which you were instrumental in. We spent our last summer working pretty much more than full time on that, and this summer, I don't know about you, but me, close to that.
Yep.
What do you think, when we talk about that word unite for safe care, where's the point, the intersection point that matters to everybody, whether they're a clinician, an administrator, or a layperson? Where is that central point that you think everybody needs to pay attention to right now in order to make medical care as safe as we presume it to be?
I think the most fundamental intersection point is the connectivity of workforce safety and patient safety. And I say that because we've spent really 25 years trying to draw attention to the number of people harmed as patients or as family members of patients. And a huge challenge in that has been blame. So there's just this entrenched default tendency to blame. So from the provider side, it's if only the patient would have been compliant, if only they had followed our directions. And from the patient side, it's if the provider had been more careful, if they had not been careless, if they had not made these mistakes. And what we fail to miss in that equation is that it's the lack of systems that support the fact that this is a complex system with lots of opportunities for things to fall between the cracks. We have to have systems that support us. And those systems need to be keeping all the persons in healthcare safe, whether they're a patient, a family member of a patient who often also experiences terrific loss, and a worker. Mm-hmm. And the workers, we've kept these on separate tracks, and I think the fact that we have now them on a single track is a big step forward. It gives me huge hope for the future that we're going to get beyond that hump of blame onto a new plateau where we see that we have so much more in common in our complaints about the lack of systems that keep us safe than what divides us.
Mm-hmm. How does that happen at every single healthcare institution?
Well, it has to happen first with attitude change. So I think that's, we talk about people not really thinking of themselves as being the victim of an unsafe healthcare system, all because it happens so much to us in sort of a one-off way. Mm-hmm. So attitude is first. We've got to realize that things can be safer, that it should be a priority, and again, by bringing the worker concerns and the patient concerns together, I think we strengthen our ability to make that a priority. And then it has to be, we have to have our policy actually walking the talk of saying this is a value. We put a value on preventing harm in healthcare. We know we can do it because we see hospitals doing it. It's just not universal. We've got to put a value on healthcare in doing that, and then we've got to resource that. Mm-hmm. Another intersection point is what we learned when we brought together patients and families to really tell us what they would like to see in terms of a policy intervention list. And Bonnie, you'll remember that what we heard many things, but what we heard really fundamentally is there's nobody in charge of patient safety in this country. So I think another thing that comes out of that attitude, out of that prioritization, is a sense that we need to have somebody in charge of safety. And right now our safety systems, our accountability systems are fractured. There's a lot of different players that have different pieces of the accountability puzzle or pieces of the prevention puzzle. They aren't coordinated. They don't talk to one another. Joint Commission doesn't talk to licensing boards, doesn't talk to medical educators, doesn't talk to CMS and their payment policy. All of that has to be better coordinated. And there our model is really the aviation industry, which made safety a priority, put resources there, and that became the overriding priority that really governs. I mean, they coordinate accountability, training, safe practices, best practices, innovation through a series of 3 coordinated agencies. And that's a good model for us. I think we need to either think about one agency or working with the agencies we've got now, like CMS, CDC, Agency for Healthcare Research and Quality, to get them really working in close coordination.
There's a way in which I want to ask 2 questions simultaneously, so I'm going to give them both, but then take probably the first one would be, how does the everyday person, remembering that I'm not alone in that when Yogi Raj died from preventable medical errors, I had no idea, and I thought it was just a very rare thing that happened, and it took me several months to realize that it was very common. So there are a lot of people like me out there who have no idea that this is an issue. What do we need to know in order to have that agency be put in place? What do we need? What happens? What can we do to make sure that agency gets placed?
I think the first thing that we can do to make sure that that we do get this to be a priority that's resourced and it gets that agency in place is to acknowledge and understand that healthcare isn't safe until something or somebody screws up or it goes wrong. It's inherently risky. There's just too many moving parts. There's too many pieces. It's like being the driver on a car on a freeway. When you go out into the freeway, you're not guaranteed a safe experience. You have to be alert. You've got to check your rearview mirror. You've got to look at every intersection because there could be somebody who runs a stop sign or isn't paying attention. They're looking at their cell phone instead of looking at the road. And that's the way I approach healthcare. You just have to go into it going, you know what, this is not as safe as it needs to be, and we need regulation to keep it safe. We need some rules of the road, and we also have to be alert as people. And for me, Vonda, that gives me confidence to do things that might seem a little bit awkward, like speaking up against authority or reporting something when I know there might be some defensiveness or there might be some attitude. I mean, I just kind of go, you know what, it's risky. I've got my part to do. I have to be careful. I have to be responsible. I'm going to do it. I'm going to report. I'm going to have that awkward conversation about the fact that you've got my mom's medication wrong. I'm going to speak up when you refer to my mom as an ovarian cancer instead of her name, and acknowledging her as a person. All those sorts of things are awkward for us, and a lot of people just feel uncomfortable about that. But if you really realize that we have a job in this unsafe system to speak up, to be aware, to know that the system isn't safe, it gives me confidence at least to kind of go, yeah, we can make this better. And that's just the first step. Then we have to take that attitude into the voting booth, and we've got to elect the right kind of people, and we've got to, your point, we've got to teach our children. This is not a place where you just walk in and surrender your responsibility to the people in charge. You've got a role here, and part of that role is watching and kind of coordinating, helping them coordinate, and being part of the team.
Is it just hospitals? Where are these issues taking place?
I'm glad you asked me the question about where these issues are taking place, because one of the things we've learned from the last 25 years in patient safety is the work that's been done has followed the money. And the money is in acute care. It's in the big places where our sickest of the sick go, and where we do we have the opportunity to do miracles, and all the research dollars, the best talent, it goes into healthcare systems that are really focused on preventing death to the people that are really sick. What we've ignored or not paid enough attention to, almost ignored, is people in other settings who we in some ways take for granted. So long-term care, ambulatory care, home care, those are all areas where actually most care happens there. It doesn't happen in the hospital. Most of it happens outside of the hospital, but the resources haven't been there. All of our patient safety research, not all, but most of our patient safety research, most of our patient safety investment has been focused in hospitals. And it's easier there because you've got something that resembles a box where you can kind of control things that happens within those buildings. The rest is much harder. I mean, that's where, coordination across the continuum, where lots of things fall between the cracks. So that's where we need to be putting our attention. Another piece of that is we've had almost an exclusive focus on preventing death. And the cost of that is that we've really lost track of all of the other consequences of unsafe care. So the bankruptcy that families go through, the depression that they experience, which can lead to divorce or to substance use or to suicide even. The despondency that healthcare workers feel when they think they might have contributed to a patient that didn't make it or had some kind of harm. All those kinds of harm, we're not even counting. We're guessing at how much harm is there, and that harm gets borne by our social service agencies, by our school systems, by our Medicare and Medicaid programs, all the different places that kind of try to pick up the pieces or help people whose harm hasn't been acknowledged and hasn't been remedied or prevented in the healthcare system. So I'd love to see us pay much more attention to the disabilities, the bankruptcies, the divorces, the depression, all those sequelae, and those can be intergenerational. I mean, people are orphaned by medical error, and we don't pay any attention to them. We think, okay, they're gonna go on and live their lives, but we've probably really shaped what that life is gonna be.
The last thing I'd love to just have you say, because I've heard this a few times and I think it does help people to really understand how you came to this. Tell us your origin story. What made you care about this personally?
So my origin story here is I've always had a strong interest in seeing justice served. It bothers me that there are people that are harmed in healthcare that don't have, that aren't treated compassionately and justly and fairly. So that is probably the core motivation here. I also just learned a lot. I started listening to patients and families because I came to this work really from the provider side. I was a lobbyist for the American Medical Association. I ran tort reform coalitions trying to make it harder for patients and families to sue. When I finally started listening to patients and families, I realized, one, that they had a huge contribution to make to prevention because they are the ones managing care in and out of the hospitals or the clinics that they go to. And we were patronizing them. We didn't really acknowledge that they had something to offer to us. So the more I listened, the more I learned, the more I realized that it was a part of the safety equation that just wasn't being paid attention to. And the more I got into that space, I realized, we've been socialized to be passive as people. We've got to really speak up and get past that passive role into an active partnership role. And that's an ambulance going to Northwestern Hospital just down the street. But so all of that is just frankly interesting to me. I like being involved in a space where we're actually empowering people to do more for themselves, more for their families, and to actually improve the system by being a full partner in it.
Do you think a national patient agency would help in that regard? Because I think about, for example, the difficulty in reporting. I mean, there's already enough stress that something unexpected or unplanned has happened. Would you see an agency helping make it easy to report, both for a clinician as well as a patient or family member?
I think a national patient safety agency is crucial. We've been talking about it for 25 years in a conceptual way. We've seen other industries improve safety by having a coordinated system of standard setting and regulations, and we just don't have that in healthcare. We've entrusted it to sort of the public-private partnership, which happens beautifully in some places, but not across the board. Other countries that have national healthcare systems have done a much better job at this than we have. So part of it is reporting. I mean, certainly reporting would be easier if we, again, made it a priority and put somebody in charge of reporting. Right now we don't have that. We don't even recognize medical error as a cause of death in the official way in which you report causes of death on death certificates. So that is a key part of it, but also the ability to investigate. So when something happens, when there's a breakout of COVID in the first nursing home, we can go in there and go, what the heck is going on here that's emerging here, and why? It's, think of it as investigating a plane crash. Getting in there in real time or close to real time to quickly investigate and figure out what's going on is part of it. And then the other part is just spreading the innovation. So we have a healthcare system that does a great job at kind of developing solutions, but we have to spread that throughout the system. And our system is a collection of businesses, basically. Some of them are nonprofit businesses, but some of them are for-profit. And we don't have a mechanism that really says this is what every hospital in the United States should be doing because it's working so well at Mayo, or it's working so well at Johns Hopkins. Why do they have no CLABSIs and you other hospital have them? I mean, that kind of spread could really be accelerated by a federal agency that takes those sorts of innovations and makes them into standards.
So that begs a question for me that if you don't want to answer it, we won't. We'll close it and I'll cut it. But when I think about systems are not set up to be empathetic. And what I know about working with you for these last 3 years is that somehow you lead with an empathetic ear, even though you are an attorney by trade and you think through a very linear and very organized lens. You have developed respect in this patient industry as a thinker, and my experience of you is that you keep your heart at the center of it. And I think when we start to ask systems to keep the heart at the center, that's a hard ask, because it's really, a system can't do that, but people can. What helps you do that? What has you lead with that empathetic position that we're asking other leaders who create these systems to do so that it really is the person at the center, whether it's the person who's the clinician delivering care or the person who's at the center as a patient receiving care?
That's a big question. So I think, but it gives me the opportunity to say this too, is systems aren't perfect. So even though I'm an advocate for putting systems into place, they also have to be watched to see if they fail or degrade. And one of the ways they do degrade is what is the point you just raised, is they tend to just treat people as if they're fungible. I mean, you hear that complaint about the Canadian healthcare system, rationing. Everyone is kind of getting this. What I think could be different, especially in healthcare, is grounding our systems and their priorities in ethics and in human rights. And we have that rich tradition. It's probably the best thing about healthcare, is that sense that first to no harm is our core principle. That's what we are all motivated to do, and that's very human. And then the other idea that is so powerful to me is the human rights idea that we're the owners of our own bodies. We're entitled to information about our bodies. We're entitled to make decisions about our bodies. And that's a fundamental right. And I think those two groundings, I think this is what distinguishes patient safety from quality. Quality is about process improvement and making sure everything runs on time and runs well and is well resourced, important part of systems. But what safety brings to it is that sense of the preciousness of human life, and the individuality of each of us as individual persons who aren't fungible. I mean, the treatment decisions I'd want for myself might be very different from another person's, even if we have the same cancer, for example. because of that specialness, that preciousness of us. And I'd love to see an organization that really prioritizes that person-centered approach, that really sees each of us as the decision makers about our bodies.
Thank you, Marty. Thank you for taking the time.
Oh, my pleasure.
And thank you for your years and years and years of work on behalf of a medical system that is as safe as we presume it to be. And I will see you in DC in about a week.
Okay. Thank you, Vonda, for zigzagging and coming into my house and meeting my dogs and having this fun interview on a rainy day in Chicago.
They were awesome bystanders, and so bye, Twiggy.
Nice Twig. You
And-
behaved well.
I actually take pictures of shoes because I'm doing a little montage of shoes. So here's our little shoes that went walking to the restaurant today.
That's
and
right.
we had our first, Marty and I both had our very first experience in a restaurant for several months, which we of course used our masks. And bye, Cubby. Are you named after the Cubs?
We presume so.
We presume so.
He came to us as a 7-year-old, and he had so much change in his life. He lived in a house on the edge of the forest preserve with a family where everybody had a handicap.
I see.
And so his whole world was the backyard, and he had a lot to deal with moving to Chicago. We weren't going to add a name change on top of that.
Right.
So
We're
we
talking
adopted
about
his
you.
name as well as him.
Well, he's super cute.
Yeah, he is cute.